Good day, everyone. My name is Nathan Ford, and I work for the Department of HIV, Viral Hepatitis and Sexually Transmitted Infections with the World Health Organization headquarters based in Geneva, Switzerland. I'm delighted to be able to provide this presentation on how to reduce opportunistic infections and AIDS deaths in Southeast Asia. Globally, there has been tremendous scale-up in access to HIV testing and starting those who are positive on antiretroviral therapy. Currently, of the 38 million people estimated to be infected with HIV worldwide, almost 28 million of these are receiving antiretroviral therapy. It is nevertheless a significant challenge to reduce AIDS-related mortality. It is estimated that there are 650,000 deaths due to AIDS in 2021, and East and Southern Africa are the worst affected in terms of the number of HIV-associated deaths. This slide shows the global distribution of AIDS deaths using the latest available data from UNAIDS in 2021. In the region of Asia and the Pacific, there are an estimated 6 million people living with HIV, and 4 million of these individuals are accessing treatment, but 2 million are not. The estimate of AIDS-related deaths is 140,000, but with very wide confidence intervals around this point estimate, ranging from 40,000 lower to 70,000 higher, up to 210,000 possible AIDS deaths per year. Advanced HIV disease is defined as having a CD4 cell count below 200 for adults, adolescents, and children over 5. This is because having a CD4 cell count less than 200 is a clear threshold for heightened risk of severe opportunistic infections leading to adverse outcomes, including death. This paper from 20 years ago is one of the original cohort studies which established that patients starting treatment with fewer than 200 cells per milliliter squared were at substantial higher risk of clinical progression than those with higher CD4 cell counts. What is the global burden of advanced HIV disease? There are no clear estimates. This modelling study, which has the goal of estimating the global burden of cryptococcal infection, calculated that in 2020 there were 4.3 million adults living with HIV who had a CD4 cell count below 200. And in this study, it allowed the investigators to model an estimated 150,000 cases of cryptococcal meningitis and 112,000 deaths in 2020. So what about the Asia-Pacific region? While there are no reliable estimates of the burden of advanced HIV disease by region or country in the region, recently reported studies from countries in the region give an indication of a very high burden of advanced HIV disease. This study from Guangxi, China, reported data from 2012 to 2016. It found a prevalence of advanced HIV disease of 42%, with no change over time. This and other studies reported risk factors associated with having advanced HIV disease, and in this study it was found to be higher in men, in people aged over 50, and in those who are migrant workers. This study from Hunan province, China, reported a similar prevalence of 43% in 2018. It found that 57% of deaths in this cohort were due to AIDS-related illness. A study across 10 provinces in Vietnam between 2015 and 2017 found that over a third of patients had very advanced disease, defined as having CD4 cell count below 100. There was no change over time, and in this study mortality was 12% at 12 months. In this study from Yangon, Myanmar, it was reported that around 50% of patients had AHD in 2017. The study reports that mortality has not declined significantly in recent years, despite scale-up of antiretroviral therapy. and more than 1 in 6 patients had disengaged from care within 5 years, contributing to unrecorded mortality. And finally, this study from North Karnataka in India reported a prevalence of 43% AHD between 2007 and 2020, and again mortality was relatively unchanged in a period of increased scale-up of antiretroviral therapy. So across the world, AIDS-related deaths remain a major public health problem, and Southeast Asia is no exception. The 3 leading causes of death among people living with HIV who have advanced HIV disease are cryptococcal meningitis, tuberculosis, and severe bacterial infections. These are the leading causes, but there are other causes that can vary in prevalence by region. For example, histoplasmosis is a major concern in the Latin American region, and talaromycosis is a predominant concern in Southeast Asia. But these and other diseases can certainly exist in many parts of the world, and more reliable data are needed on regional distribution of each of these major infections. Over the last 10 years, the World Health Organization has issued a number of global guidelines to support the management of advanced HIV disease. Clinical guidelines on the management of skin and oral manifestations, including conditions like Kaposi's sarcoma, were published in 2014. In 2017, WHO published guidelines on how to manage advanced HIV disease in a public health approach. In more recent years, guidelines on the management of histoplasmosis and updated guidelines on the management of cryptococcal disease were published, and there are a number of guidelines on various aspects on the management of tuberculosis that are regularly updated, as this is an area of intense innovation in prevention and treatment and diagnosis. So now to focus on the guidelines for the management of advanced HIV disease in a public health approach that were published in 2017. These guidelines promote the delivery of a package of care for all people presenting with advanced HIV disease. The package includes screening for tuberculosis and cryptococcal disease. It also includes prophylaxis and preemptive therapy for bacterial and fungal infections. Rapid initiation of antiretroviral therapy is critical and is indicated for the majority of patients, except for those with signs and symptoms of disease suggestive of active TB or cryptococcal disease, as this can carry the risk of IRIS. And enhanced adherence support is emphasised, considering that this is a group of patients who will be receiving multiple medications. The Advanced HIV Disease Guidelines also emphasise various considerations with respect to service delivery. The package of care should be delivered to anyone presenting to care for the first time if they have a CD4 cell count below 200, and also to those who are re-presenting to care after a period of disengagement. It can be provided at all levels of the health system, and it can be provided by doctors, nurses, and mid-level workers, provided they have appropriate training. And the package includes diagnostics, preventive therapy, and antiretroviral treatment, as we have indicated earlier in this presentation. This map illustrates that the package of care has been fully or partially adopted in national policy in many countries in the world, including countries in Southeast Asia. However, policy adoption, whether full or partial, is not the same thing as delivery of the package to all those in need across all levels of the health service, and much more work is needed to support full and complete implementation. Earlier this year, the World Health Organization published a policy brief highlighting the fact that patients with advanced HIV disease can be further categorized into 2 distinct groups. There are those at high risk of adverse outcomes but not yet experiencing adverse outcomes, and this group of patient needs the AHD package. And then there is a second group, those who are already seriously ill. This is a group that needs more intensive care and support, which for many may require hospitalization. It is important to stress that outcomes of people living with HIV who are hospitalised is currently very poor in many regions of the world. Recent systematic reviews have found that 20% of people living with HIV admitted to hospital die in hospital, and among those who are discharged, 19% are readmitted within 1 year and 14% die post-discharge. So this is an area that needs urgent attention, and with a number of suggestions provided in the WHO policy brief, it can be further improved to provide management of people who are seriously ill and hopefully avoid these adverse hospital-based outcomes. I wanted to highlight another important area of recent work from the World Health Organization that is of relevance to those with advanced HIV disease. This is the development of a list of priority fungal pathogens. The list was published last year and includes 19 priority fungal pathogens, of which 4 are of particular relevance to people living with HIV: cryptococcosis, histoplasmosis, pneumocystis, and Talaromyces. The purpose of the list is to draw attention to the important gaps in terms of diagnostics, preventives, and therapeutics for the effective management of these pathogens, and also to raise concern about the development and spread of antifungal resistance to those drugs that we do have to prevent and treat these diseases. It serves as an advocacy document to highlight where more intense research and development is needed. My last 2 slides serve to highlight the key challenge we have in estimating the burden of advanced HIV disease and effectively following up people living with HIV to provide the care they need. It is increasingly appreciated that the cascade of care is not a linear cascade, but is rather cyclical. People living with HIV can enter care through a variety of entry points, and for a number of reasons they may drop out of care at each of these steps and re-enter care after a period of disengagement. It is important to recognise and account for these complexities in order to reliably monitor the burden of advanced HIV disease in countries. The world has committed to global targets of 95, 95, 95 by 2030. This means that 95% of people are diagnosed as HIV positive, and 95% of those who are diagnosed positive are put on antiretroviral therapy, and 95% of those are virally suppressed by 2030. But this doesn't account for mortality. So the 95, 95, 95 cascade accounts effectively for outpatient program successes, but fails to capture advanced HIV disease and AIDS-related deaths. WHO is working to establish a monitoring and evaluation framework to support countries to report reliable cascades for AHD care, including the number of AIDS deaths disaggregated by cause. This will help national programme managers to direct resources to where they are mostly needed, and in order to achieve the goal of reducing opportunistic infections and AIDS deaths. So in summary, reducing AIDS deaths remains a key programmatic challenge. The Advanced HIV Disease Package aims to cover the leading causes of death within a public health approach. Recent guideline updates have been issued to support improved prevention, diagnosis, and treatment of leading infections and causes of illness and death. Tracing and re-engagement is a very important aspect that has recently been recommended in WHO's consolidated guidelines, and focused hospital care and post-discharge follow-up have also been emphasised in a recent policy brief for those who are seriously ill. And with that, I would like to thank a number of colleagues at WHO who provided input into various aspects of this work, and I would like to specifically thank Tui Lee for her support to WHO's work on advanced HIV disease in recent years, and for inviting me to give this presentation. And thank you to all of you for your attention.